I'm thrilled to introduce three panelists who are going to teach us about data and innovative health IT solutions that can help combat maternal mortality. So I'm going to ask, as the panelists come on, that each of them introduce themselves and tell a little bit about the organization they represent. So with that, I'm going to go in this order: Johnese, and then Elliott, and then Jennifer.
Hello, my name is Johnese Bostic, and I bring you greetings from South Carolina, where I am the Women's Health Informatics Analyst at the South Carolina Primary Healthcare Association. I bring to you over 12 years of public health experience working with state government, nonprofit sectors, community health centers, statewide health coalitions, and other stakeholders in the areas of public health programming, where we work to eliminate health disparities and to improve health outcomes, program evaluation, and also grant management, facilitation skills, as well as project management. And so, as previously stated, I am the Women's Health Informatics Analyst at the South Carolina Primary Healthcare Association. And the Primary Healthcare Association is a unified organization of the community health centers that are located here in South Carolina. And so they represent public and private partnerships that work together to improve the health status of their respective communities. And so we were established in 1964. It is a community-based nonprofit organization. And again, we want to provide comprehensive, high-quality, patient-focused healthcare services in a culturally appropriate manner here in South Carolina. So that's just a little bit about myself and the SCPHCA.
All right, Elliott.
Good morning, everyone, and I'm honored to be here today. So I chair the California Maternal Mortality Committee, which is because California has 500,000 births a year. Size of a bigger than most European country. It's the largest maternal mortality review committee in the country. And we formed in 2006, and since that time we've reviewed 1,000 maternal deaths, which is a terrible burden to have to bear, and it's really driven us to do quality improvement work, which is the focus of our activities for the last decade. If you go to the next slide, one of the things that we were able to do, and I'm talking today, I was asked to talk about the role of data that's available in the healthcare system to drive improvements for maternal mortality. We've heard wonderful discussions of patient stories, and you can't have stories without data or data without stories. And it's super important to be able to merge the two. With our Department of Health, we've been able to free the data, which is we get it in our freestanding California Maternal Quality Care Collaborative based at Stanford. We've been able to receive feeds of birth certificate data every month for every birth in our state. And then working with our hospitals to get hospital discharge diagnosis files also on a monthly basis, now about 45 days old, for both mother and baby, and we link these together on a monthly basis and then turn them around to hospitals to help drive quality improvement in maternity outcomes, particularly mortality and severe morbidity. This is something that can be done. Currently, with any state that decides to do this, you may have to change regulations and so forth, but there is a big emphasis here in this maternal mortality crisis to use data that's existing. So this is recycled green data. Next, we've been able to achieve some, next slide, some pretty special things in California. If you look at the top right, you can see maternal mortality rates in the US versus California. It's a little small here, but US is red, California is blue. When we started doing toolkits and maternal mortality reviews in 2006 and the quality improvement projects, we dropped our rate in California to be the same as in Europe. Now, we dropped it in all races by about 50%. So that's the good news. The bad news is that we still have a threefold difference between Black mothers and white mothers. So Black mothers dropped 50%, but they're still 3 times higher than white. One of our recent QI projects is that there's more interventions in Black women. There's more interventions than we'd like to see in obstetrics as a whole. And we were able for the first time in the country to have a major drop in cesarean birth rates by doing quality improvement work involving as many partners as possible. And you could see, again, US in red, California in blue, and we were able to drop all races from a rate of 26% for first birth C-sections to 22%. So this is, again, turning back to data that's available and making it open source to as many places as possible. Next slide. This is a report on the use of data for improving maternal outcomes done under the auspices of ASTO and others that's available online. This is now, the slides will be shared and you can look at these links looking at how states have approached this in multiple states, Medicaid data sets, perinatal quality like Michigan, which was discussed earlier, and here in California. And then race inequity. One of the keys here is that we've been able to turn race and ethnicity data that's gold standard available in the birth certificate to apply that to daily application of data. There's a big need for hospitals to improve their race and ethnicity reporting. In many hospitals, there's 30, 40% other or unknown for race and ethnicity. That's not acceptable. We have to know what the outcomes are by race and ethnicity. So using the birth certificate is a key one. The last slide next is about how you can harness artificial intelligence, which was asked about earlier in the checkbox, which is how to use vital signs and other data that's monitored in the hospital to turn that into early warning triggers. This gets around the denial and delay that Fran was talking about. It can be done in the outpatient, but also in the inpatient here. So these are 3 studies, for example, that show that you can use basically early warning triggers in the hospital, in the EHR, to detect sepsis, hypertension, and cardiac dysfunction. It didn't work so well on hemorrhage. But these, in combination with the bundles and toolkits that are now available through our state perinatal quality collaboratives, can lead to some significant advances. So I'm going to end now, and we'll go on to back to Denise.
Okay, Jan, Jennifer.
Good morning, everyone. Thank you, HIMSS, and I'm honored to be part of this really important discussion. I'm Jennifer Stoll. I lead government relations and public affairs for OCHIN. In case you don't know who we are a national nonprofit health IT and research network, and we operate in 47 states. Many of you may not know us, but we work with a lot of your health centers that are supporting in part of the top 10 states listed here. Our mission is to ensure that health technologies never stand in the way or cause health disparities. And so we work really hard to employ and ensure technology enables the provider and drives care coordination. So you may best know us for our integrated health record system that we support across the country, a shared record system for over 130 unique, both small and large urban and rural health centers, community health centers, lookalikes, Ryan White centers, correction facilities, and others. And so we have one of the largest data repositories of safety net patient data. And it's really interesting because in the last 2 years, I had my team pull data around the maternal health care structures, and our health center saw in the last 2 years around 60,000 expectant moms, and looking at some of their outcomes is something that I look forward to talking to you today about. The other thing I would flag is our mission supporting underserved communities. I don't think we think in terms of the fact that health centers now are delivering a lot of prenatal care and maternity care. About half of the health centers that we work with and half of the health centers across the country provide these services for the country's most at-risk patients. And what's really amazing about what health centers do is their outcomes are actually better than other care delivery systems. So, being able to provide them with technology to be able to support their work is our honor. And I really appreciate being able to be part of this panel and share what we're learning.
Why don't we go ahead and get started with our first question? And we're going to talk about social determinants of health. We've touched on it a bit in the video. So as we look at social determinants of health, we know that maternal mortality is a social determinant of health issue that may require different approaches to resolve this crisis. So how can we leverage the cross-sector collaboration and all the systems interoperability to address the maternal mortality crisis at the state level? And Johnese, I'm going to start with you, and then we'll circle back to you, Jen, and then Elliott. So I'd like for each of you to address this question based on your experiences with your organization.
Yes, so as the Women's Health Informatics Analyst, my role is to implement quality improvement tools and workflows and processes and to assist our health center staff with the management of data in patient care and quality outcomes for women's health. And also one of the roles I have is to sit as a member of our state's, it's called the South Carolina Birth Outcomes Initiative. And this is an initiative that's led by the South Carolina Department of Health and Human Services, our hospital association, Blue Cross Blue Shield, as well as our state's public health agency, made up of almost 100 or more stakeholders. And I represent the Primary Healthcare Association. And over these 100 stakeholders or plus, our goal is to improve health outcomes for all moms and all babies within our state. And so one of the things that we are tasked with through several work groups, we have work groups like access and care coordination, behavioral health work groups, data. We have a quality and patient safety work group, safe sleep work group, newborn care coordination, as well as a health disparities work group. And the things that we're working on is how do we eliminate inductions for non-medically indicated deliveries prior to 39 weeks. We look at things like making 17P, which of course is a compound to help prevent preterm births, available to all at-risk moms with, with a no hassle factor. We are looking at implementing universal screening and referral tools through SBIRT, and having those into physician offices and in baby-friendly designated hospitals and breastfeeding. So this South Carolina Birth Outcomes Initiative has several members who are working together to make sure that we're driving better outcomes, maternal health outcomes here in the state of South Carolina. Again, through all the initiatives that we have, through our work groups, and we're made up of several different entities. This is how we bring as a cross collaboration across the state, meeting on a monthly basis to talk about, again, how do we improve the health for all moms, all babies here in South Carolina. And so at this point, I'll pass it on to Elliott.
I think Jennifer was next. So
I'm sorry, Jennifer.
Thanks, Denise. Yeah, so as you're probably aware, health centers have been on the forefront of social determinants collection of health information. And so it's been not only just nice, but it's part of what they do every day. So I wanted to tell you a patient story, which I found very fascinating, and it really frames the need for standardization and data collection around social determinants so we can connect patients with the services that they need on the back end, but also the improvement of what happens when we make and help those that are serving our most at-risk patients improve the systems that they have. Because again, it's only as good as the data system that you're collecting and putting data in. So we have, the system that you have has to be high quality, and then you have to have data standards around social determinants. So I wanted to tell you a story about one of our members, Lifelong Medical Care. They're based in Alameda County, not too far from Elliott. And they were able to recently upgrade their EHR systems. They're one of our members. And what they did is they looked at, because they collect social determinants data in a standardized way, for the first time, they were able to look at a patient who was experiencing homelessness. For this purpose, we'll call her Barbara, in a very unique way. And so they were able to use the OCHIN EPIC system for the first time to coordinate care across multiple health centers, because the whole network was able to upgrade their EHRs, and they were able to better coordinate for labs and ultrasounds without duplications. And because they were sharing records, they had the interoperability and care coordination, but also were able to do messaging back and forth from the providers to really coordinate Barbara's care for the first time. And so our nurse practitioner, Kim Cardosa, says, now we can accommodate our patient wherever she's staying at the time, and we can follow her, and she can follow her own care via using her cell phone. It's a beautiful solution for a complex patient in an unusual time. And this was during COVID as well, which added, we're still in COVID, but added an additional set of complexity. But because they were able to screen Barbara in a standardized way, the health centers were able to coordinate her care and share information, because they were able to upgrade their EHR systems and to be able to drive interoperability. I mean, this is really where we need to take it, and also be able to get her the services that she needs on the back end once baby is born. And we have to be able to make these investments as part of our public health infrastructure, because our primary care delivery system now is really being delivered through health centers across the country. So those are my thoughts.
Just to briefly add on to Jen's comments, because I wholeheartedly agree, and I think the federally qualified health centers have been the best positioned and the best to implement this kind of approach. But screening for social determinants, whether it's housing or food insecurity, transportation inadequacy, or exposure to toxic stress from racism, is not classically a part of screening in prenatal care in many sites, particularly in private practice sites. And partly because many physicians don't know what to do when they find that, and don't have referral networks. So what we're trying to encourage our hospitals to partner with the prenatal care sites is that develop lists of resources that then can be used by everyone, both inpatient and outpatient. Secondly, I'd like to really emphasize the need to be tracking social determinants in coding. There are new ICD-10 codes, Z codes for social determinants that are being strongly encouraged by HHS, but are not really out there in practice, because if we don't track it, we can't really monitor it, and we really need to do both. So back to you, Denise.
Thank you. And I want to make sure we get a chance to touch on two areas before we close today. One will be the modernization projects and work happening with public health. And then the second area will be the new advancement of the Omnibus Act. So I'm going to ask that we talk a little bit about the public health data modernization efforts and how that will be helpful. So Jen, I'll bring it back to you, and then we'll move right into talking about the Black Maternal Health Omnibus Act of 2021. So Jen, if you would just briefly touch on what you believe the role of public health data modernization will play in this effort, and then we'll talk about the Omnibus Act.
Yeah, I think I touched on it earlier. It really comes down to, in my mind, a pretty simplified approach, and that is, how do you collect data and then how do you transport it? And if we're not collecting data in a standardized way in good quality systems, you can't transport, right? And you can't share it to improve coordination, and you can't provide reports back to the state because it's not transportable. You can't provide reports back to the state or to the feds to be able to give be able to have information to be able to make changes and adjust in policy. So, things that we're encouraging, and really shout out to HIMSS and the incredible work that the HIMSS government relations team did to advance the policies around public health modernization. But also thinking about making sure that those funds that are coming down through the CDC are being spent in the most effective way, which is helping upgrade systems on the most fundamental way. I know there was also a question about AI and how does AI play into this. In our world, Medicaid is by far the largest payer. We have 100,000 patients that have been screened positive for homelessness or experiencing housing insecurity. Transportation and hunger are very big issues in the network we support. But health centers are struggling between, do I have a high quality EHR or do I put that into patient care? We shouldn't have to have them make those decisions. And if we don't help everyone participate in the data revolution and provide programs that help subsidize those costs, we're going to constantly having net disparities in the technology. So I think that's my key point here is we have to help everyone participate in the data revolution. We cannot leave folks out.
In our last few minutes, I want to make sure we touch on the advancement of House Resolution 959, the Black Maternal Health Omnibus Act of 2021. So if the advancement is successful, what complementary state legislative actions must occur to make sure we achieve the most significant impact on this crisis? I'm going to ask Johnese to give us a few insights, and then Elliott, and then each of you can provide a 1-minute takeaway message for the group.
If this act is passed, I think one of the important things that will happen that would need to happen is making sure there's funding for community organizations who have a focus on maternal health, making sure that they have those resources to be those non-traditional partners to help get the message across. Also looking at ways that we can support our moms who have substance use disorders. I think that will be important for us to look at as we're looking at, integration of care and care coordination, making sure we're looking at behavioral health, making sure that our providers are also trained to provide holistic care for our patients so that we're not just maybe going in for a visit that is a maternal visit, but we're also looking at everything that makes up the whole person and making sure that we are addressing this at each of these visits, looking at veterans who are postpartum, veterans who might be pregnant. So looking at veterans affairs and substance use and making sure that the social determinants of health is also addressed, at these visits. We have the Azara healthcare platform here in South Carolina, and it's an overlay to our EHRs and making sure that we have dashboards that are set up on top of our electronic health records to ask those questions regarding social determinants of health and create those dashboards and reports, and so that our providers know, a better insight as to what their patients are going through, other than just what they're presenting for as a visit for that day. And I'll hush so that we can keep going, and so everyone can have a time, because I could keep going on this, but I'll stop. Elliott.
No, thanks, Johnese. I think one of the key things that's coming down, both the Momnibus and the Mommy Act in the Senate, is expansion of Medicaid to a year, postpartum expansion to a year. Because as I said earlier, 1/3 of maternal deaths happen in the postpartum period, at least a week after discharge. Cardiovascular complications in particular are the largest killer. 25% of maternal deaths are in that cause alone. And there's a dominance of those in this postpartum period. And these are women who've been going to ERs for multiple complaints and other settings, not necessarily OB settings, but they really need to still be in care for that year. This would also improve care for substance use disorders and for mental health disorders, which are two additional major killers that don't often end up in our statistics because they're not in the WHO classification for maternal mortality. They are potentially in pregnancy associated or related mortality, but they're important deaths that occur in that time period. So postpartum expansion does require state participation. These acts give a lot of money to states to do that, but the states still have to sign up.
And Jen, I'll give you the last minute before we begin to wrap up to leave any final comments you'd like to have.
No, from the ambulatory side, from the primary care side and the public health side, I think it's super important that we do everything we can to drive care coordination. And this is a great laboratory to be able to improve that. One of the things that I think it makes it very difficult for ambulatory providers is that they don't see the hospital data. So even as Elliott was talking about the incredible program that they were able to do in California, we don't see a lot of that data. Even if we get ADT feeds, and we know when folks are in and out of the emergency room and the hospital, but if we can't see a complete medical record, and there are lots of solutions around health information exchange, but you have to have participation and incentives to be able to participate in health information exchange. This is a really key laboratory for us to make sure we improve care coordination and health information exchange and interoperability.
All right. Well, thank you, Johnese, Jen, and Elliott for sharing the policy strategies and practical and technical solutions that states and partners that everyone can leverage to address the maternal mortality crisis. Thanks again to Dr. Ferguson, Fran A, for underscoring the human element and critical need to act now. And thank you as well, Deborah. In addition to the National Remote Maternal Health Monitoring Demonstration Project, we encourage attendees to follow the HIMSS Global Health Equity Network, the work of our government relations team on the HR 959, the Black Maternal Health Omnibus Act of 2021, as well as local efforts supported by our HIMSS chapters to stay abreast of policy advances related to maternal health. So thank you for your time and attention. And now I'm going to turn it back over to Valerie for our wrap up.
Greetings, everyone. In addition to the HR 959, the Omnibus Act, we really strongly encourage you to take action. And what we mean by action is connect with your local HIMSS chapter. We have chapter advocacy stakeholders in just about all states. For those of you who want to address this issue and who are interested in interventions that leverage technology solutions that were talked about today, those are the best folks to sort of talk with you about how to advance remote patient monitoring, telehealth, wearables, and really a core issue here is interoperability, the ability to connect systems and data and information to tell us more about our communities and about ourselves. Again, I would like to reiterate Fran's message to enroll in the state RPM demonstration project. I would also like to just give a bit of credence on some of the work we're doing at the national level to improve maternal mortality reporting through modernization, which was touched on by our wonderful panel. And then finally, just to wrap it up, I'd like to just share the Global Maternal Health Tech Challenge. Again, a big plug for this opportunity that will really emphasize something that Johnese brought up, the behavioral health and care coordination components to this challenge, to this critical issue. You'll find the links to these resources and these challenges here in the slide deck, which will be shared with you after the completion of this web event. And with that, thank you very much. Goodbye, everyone.